Hello, I'm Ty Mason of the DiabetesCouncil.com, a researcher, writer, and I have type 2 diabetes. Today I want to talk about gestational diabetes and induction. After you watch the video today, I invite you to check out the description box for my new ebook. This is one of the most comprehensive diabetes meal planning books you can find anywhere. It contains diabetes-friendly meals and recipes for different goals such as 800 to 1800 calories per day meal plans, diabetes meal planning tips and tricks. There are tons of diabetes-friendly recipes for everyone. Now, according to Sam McCulloch in his article on bellybelly.com, yes, that's an actual place for pregnant ladies to go, bellybelly.com. Gestational diabetes was once a relatively rare condition occurring in about 4% of pregnancies. In recent years, however, the rate of women developing GD has doubled, and experts believe the incidence of the disease will keep increasing. Now, most women with gestational diabetes are told by their care providers that they will need to be induced before their due date, destroying their hopes for a natural and intervention-free birth. Now, having gestational diabetes can have a big impact on mothers' and babies' health during pregnancy, but does it really need to change how we give birth? You see, the question is, why do I need to be induced with gestational diabetes? The real question should be, must I be induced with gestational diabetes? And we're going to look at that. First, let's answer the question, what is gestational diabetes? Gestational diabetes is a condition that only occurs during pregnancy. Certain pregnancy hormones interfere with your body's ability to use insulin. Insulin converts blood sugar into usable energy, and if this doesn't happen, blood sugar levels rise. Insulin resistance can cause high blood glucose levels and can eventually lead to gestational diabetes. Some women will have many symptoms and some will have none. Many women can manage the condition without treatment other than a dietary and exercise change. Around 20% of women will need insulin injections. So for many women, well-managed diabetes means they can still have a healthy baby and normal births. Now, does gestational diabetes mean we have to have induction of labor? Well, many healthcare providers routinely recommend that women with gestational diabetes be induced at around 38 to 39 weeks. The most common reasons given for induction at this gestation are to prevent stillbirth and to prevent babies growing too large for vaginal birth. However, the evidence related to induction for women with gestational diabetes comes from the review of one trial, which looked at 200 women who either had gestational diabetes, type 1 or type 2. Now, the World Health Organization states this evidence for induction before 41 weeks gestation is weak, and induction before 41 weeks should not be suggested if gestational diabetes is the only medical issue. The American Congress of Obstetricians and Gynecologists guidelines for gestational diabetes also do not recommend induction of labor before 39 weeks for women with well-controlled gestational diabetes. The evidence for induction of labor is neither strong nor clear. A recent review looking at the evidence supporting indications for induction concluded there wasn't strong enough evidence for induction of women simply based on gestational diabetes. Now, why would you be induced? There are several reasons why healthcare providers will recommend induction for women with gestational diabetes. What is important to remember is that many of these complications are more relevant to those women whose condition is not well managed. Now, one reason that it will be suggested to you to be induced is a large baby. It's called macrosomnia, and it's considered to be a problem if you have gestational diabetes. You see, the extra sugar in your bloodstream crosses the placenta and triggers your baby to make more insulin. This can cause your baby to store more fat and tissue and be larger than average, over 9 pounds. This condition is impossible to diagnose before birth. Now, doing ultrasounds in the 3rd trimester allows healthcare providers to make an educated guess, but the estimated weight prediction can vary from the actual birth weight by up to 15%. In the U.S., 10.4% of babies weigh more than 8 pounds at birth. If you have gestational diabetes, there is a 13.7 chance of having a baby over 9 pounds. So the risk of having a large baby is increased, but not by a great deal. Keeping your gestational diabetes well managed can reduce the risk of a large baby by up to 50%. Now, if healthcare providers believe a baby is already large for gestational dates, they might suggest early induction to avoid a C-section later. This is due to a fear of shoulder dystocia, which is when the baby becomes stuck in the pelvic outlet because his shoulders are too wide to pass through. Most healthcare providers consider this a medical emergency needing interventions, such as an episiotomy, forceps, a vacuum delivery, or even an emergency C-section. Stillbirth is another reason given, and the risk of stillbirth is higher for women with type 1 or type 2 diabetes, and this is often used as an indication for induction for women who have gestational diabetes. High blood sugar can cause blood vessel damage to the placenta, which means poor oxygen and nutrient supply to the baby. Now, this can lead to health complications for the baby or to stillbirth or death. However, these complications rarely occur in pregnancies where gestational diabetes has been diagnosed and is well managed. Another reason you might be asked to be induced is preeclampsia. Now, this is a condition which involves a combination of hypertension, raised blood pressure, and the presence of protein in the urine during pregnancy. The condition usually occurs after 20 weeks gestation and affects about 3% of all pregnancies. Now, around 3% of cases occur without gestational diabetes, and just over 6% occur with gestational diabetes. Most cases of preeclampsia are mild and, if managed, have no effect on the pregnancy or the baby. Management usually involves lowering blood pressure by diet, exercise, or medication. Continuing high blood pressure can reduce blood flow to the placenta. Now, this means less oxygen and nutrients for the baby, which can lead to preterm labor, low birth weight, growth restriction, or even stillbirth. In some cases, the condition becomes more severe and develops into eclampsia, which occurs in 1 to 2% of pregnancies. Eclampsia can cause placental abruption, seizures, or preterm labor, and can be fatal to both the mother and the baby. The only way to cure preeclampsia is for the baby to be born. Induction for preeclampsia is usually recommended at 37 weeks, as it's believed this reduces the risk of complication. Now, a study of pregnant women with mild preeclampsia found induction of labor between 34 to 37 weeks reduced the small risk of adverse maternal outcomes. However, the risk to the baby was increased, including complications of preterm birth such as respiratory distress syndrome. If you have been diagnosed with preeclampsia and have gestational diabetes, you need to discuss with your healthcare provider the benefits and risks of expectant monitoring and management of your condition. Now, what if after everything is said and done you need to be induced? Well, despite your best efforts to avoid it, induction might become medically necessary if you do have gestational diabetes. This can challenge your attempts to have a natural birth, but you might avoid further interventions and a C-section. There's a number of ways labor can be induced, and depending on the urgency of your situation, you might be able to negotiate a little intervention as possible. During labor, your blood glucose will be monitored every hour to ensure it stays within safe levels. If your gestational diabetes has remained under control during pregnancy through diet and exercise, it's unlikely your blood glucose levels will rise. If you've been treated with insulin, it's more likely your blood glucose will increase during labor, and if that happens, you might need to have insulin and glucose administered through a drip. Now, your baby will need continuous monitoring if medical forms of induction such as Pitocin or Syntocin are used. This is because artificial oxytocin can cause your uterus to contract strongly and cause your baby to become distressed. Continuous monitoring will limit your ability to move and might make it harder for you to cope with contractions. You can request an epidural, which might lead to further interventions and a C-section. If you're able to avoid these methods of induction, you might have intermittent monitoring. Induction is challenging to cope with, but if you have good support from your healthcare provider and your birth team, you can have a positive birth experience. Gestational diabetes is now more commonly diagnosed, but it doesn't have to mean a highly interventive birth. If your condition can be managed, you should be able to have a normal birth. If induction is necessary, make sure you are well informed about the reasons. All medical intervention comes with risks, so it's important your healthcare provider answers all your questions and you take the time to make the decision that is best for you and your baby. I hope this answers your question. Don't forget to get my new ebook, and please subscribe to our channel for many more videos like this one in the future. I want to thank you so much for watching. I'm Ty Mason.